Can my 39-year-old daughter go home with intensive care at home with an uncuffed tracheostomy and dialysis after a stroke? This is a question from Leonie that I have today, and I will answer her question today on this video blog. My name is Patrick Hutzel from intensivecarehome.com. So let's look at Leonie's question in more detail. Leonie's daughter has been in ICU for a long time. She now has an uncuffed tracheostomy and she's also on dialysis after stroke. And Leonie wants to get her daughter home as quickly as possible. She says she has no quality of life in ICU and she wants to find options to go home as quickly as possible. So that means because she's got an uncuffed tracheostomy, that also means she's off the ventilator now, which is fantastic news, right? You can only really use an uncuffed tracheostomy in adults when patients are off the ventilator, right? And when they are managing to swallow their saliva, that's really the only way you can use an uncuffed tracheostomy. You can use uncuffed tracheostomies in children, but that's a whole nother story for adults in general, especially for ventilated adults with tracheostomy. You can only use a cuffed tracheostomy. What's the difference between a cuffed and an uncuffed tracheostomy? Because sometimes when we have inquiries, families don't know the difference between cuffed or uncuffed. You know, when we ask them, is it a cuffed or an uncuffed tracheostomy? They don't even know what it means. And it's really important that, you know, you understand the difference. So let me just show you this. This is what a tracheostomy looks like. And you can see there's a cuff here at the end that you can inflate. You can see that. That's blocking secretions from going down the throat, right? And it also, for a ventilated patient, makes sure that the oxygen is staying in the lungs. Whereas for someone that's off the ventilator, an uncuffed tracheostomy means the cuff has gone, and you know, it's not only that you're taking the cuff down, it's really that you're changing the tracheostomy to a tracheostomy without a cuff. So that's the difference. So that's coming back to Leonie's question. Is it possible for a daughter to go home with intensive care at home with an uncuffed tracheostomy and dialysis after stroke? Yes, it absolutely is possible for your 39-year-old daughter to go home with intensive care at home, an uncuffed tracheostomy and dialysis following a stroke. Depends a little bit on several criteria, of course. Here's a breakdown. So let's repeat here. What's an uncuffed tracheostomy at home? An uncuffed tracheostomy is often used when patients do no longer require mechanical ventilation, but still need airway support, i.e. secretion management, which means suctioning, right? Regular suctioning. And also if they can swallow their saliva. And also if they can even eat or drink. So this is generally manageable at home with proper ICU nursing support 24/7, suction equipment, monitors, you know, spare tracheostomies for emergencies, God forbid, you know. But the most important ingredient here is that your daughter has 24-hour nursing care with intensive care trained nurses, which is what we do here at Intensive Care at Home. So then let's look at dialysis at home. Home dialysis typically is done by a peritoneal dialysis or a home hemodialysis. It's possible, but it requires that your daughter is medically stable. It requires a clean and safe home care environment, of course, and obviously nurses that are trained on dialysis, right? That's one of the ingredients. Then also the level of neurological impairment, i.e. cognitive function, mobility, ability to communicate, impacts whether home care is safe for stroke recovery needs, because you mentioned that your daughter had a stroke. If she cannot protect her airway or requires frequent intervention such as suctioning, you know, nebulizers, you know, if she can't swallow, then the ICU also needs to consider whether they need to put back in a cuffed tracheostomy, right? But, you know, again, she will need 24-hour nursing care with intensive care nurses, and that is actually evidence-based, and you can look that up on our mechanical home ventilation guidelines that are evidence-based on our website at intensivecarehome.com. Also, you know, it needs regular doctor oversight, respiratory physician in particular, you know, a pulmonologist, but we can help you with setting that up. Even the ICU might be able to help you set that up from a doctor perspective, whereas we can be fully responsible for the nursing care, you know. So just talking about funding, funding in general is not the issue because, once again, patients and families want intensive care at home. It's also a case of that our service cuts the cost of an intensive care bed by around 50%, 50. So that's obviously of interest for hospitals, no question about that. And we free up a bed, so it's a win-win situation all around. So with intensive care at home, we are currently sending our ICU and critical care nurses into the home 24 hours a day. We are providing the following: a genuine alternative to a long-term stay in intensive care, which is exactly what Leonie was asking for her daughter. Intensive home care services for ventilated adults and children with tracheostomy care without ventilation, home care nursing for patients on non-invasive ventilation, such as home BiPAP, home CPAP without tracheostomy, home TPN, home IV potassium and home IV magnesium infusions, IV fluids, and IV antibiotics. We're providing central line management, peak line management, Hickman's line management, as well as port management at home. We're providing nasogastric tube, PEG tube, and pitch tube management at home. We're using cough assist machines for our clients for airway clearance, and we're providing palliative care services at home as well. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to the emergency department. That also means we're in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs between $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per day, and we're freeing up the most sought after bed in the hospital, which is the ICU bed. But more importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. And of course, quality of life at home is much improved at home, surrounded by families. With intensive care at home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas where an NDIS approved service provider, TAC and WorkSafe in Victoria, as well as the Department of Veteran Affairs all around Australia. Our clients and we as a provider have also received funding through public hospitals, private health funds, as well as departments of health. We are also currently the only service provider in Australia that has achieved third-party accreditation for intensive care at home nursing in 2025. We have been achieving this level of accreditation since 2012. No other service provider has achieved this high level of accreditation in the community and has created more intellectual property for intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. If you are at home already and you're watching this, or if you're stuck in an ICU, or if you're going to hospital and ED all the time, and you realize that you don't have the right level of support, I'll give you another tangible and real-world example so that you can see how we can help you. One of our first clients, when we first got started in 2012, was a client who was at home, initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, support workers are not able to look after ventilation and tracheostomy clients. That is simply dangerous and negligent. Having support workers looking after a client at home on a ventilator with a tracheostomy is like flying the airplane with a cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies 24/7, or even at high risk of dying. They don't have a team of critical care nurses looking after them 24/7. This is actually evidence-based, and it's documented in the mechanical home ventilation guidelines that you can find on our website at intensivecarehome.com. Think about it. In an intensive care unit in a hospital, you wouldn't have support workers looking after a critical care patient on a ventilator with a tracheostomy. So why would anyone in their right mind would do that in a home care environment in the community? So this client found out about us eventually, and the ICU that he went back to all the time and more or less was living in also knew about us and eventually reached out to us. And we were able to prove our concept with this client very fast. When we worked with the client, we sent him intensive care nurses 24 hours a day, and he was able to live a good quality of life at home, and he never ever went back into ICU ever again while we were working with him, and we were proving our concept there very fast. We can do the same for you if you're not safe at home, which includes the advocacy for funding that goes along with it. We have always successfully advocated for our clients. Otherwise, we would not be in business. The same is applicable for those stuck in an ICU, similar to our case study today, or going back to ED all the time. Reach out to us. We'll make it happen for you as well. We can take you through the right steps, including NDIS or other funding bodies, and the advocacy that needs to go along with it, which is also why we are providing level 2 and level 3 NDIS support coordination. We have a team of NDIS support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Riches, one of our NDIS support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog. We're also providing TAC case management and WorkSafe case management in Victoria. If you're an NDIS support coordinator or a case manager from another organization watching this, and you're looking for nursing care for your participants, please reach out to us as well. If you are looking for funding for nursing care for your participants and you don't know how to advocate for it and what evidence to provide, I encourage you to reach out to us as well. We will help you with the right level of funding and with the right level of advocacy. We're also providing NDIS specialist nursing assessments done by critical care nurses with a legal nurse consulting background. If you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic, high-performing team of critical care nurses in the community, we are employing hundreds of years of critical care nursing experience combined. If you are looking for a career change, we're currently hiring the jobs for critical care nurses in Melbourne, Sydney, Brisbane, Albury, Wodonga, in Bendigo, in Geelong, and in Warragul in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I do have a disclaimer because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients also do want the same staff coming over and over again because they are so vulnerable and so special. That's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We are looking for consistency, and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts, and if you're really keen on building relationships with us and with our clients, of course. If you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds. In most cases, you won't even pay for it. Even if you do pay for it, it is much more cost-effective than what you're paying for in ICU and ED, and you get the same level of care. If you're a hospital executive watching this and you have bed blocks in your ICU, ED, and respiratory wards, home TPN, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US or in the UK and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecareathome.com. If you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you think about this video or what you want to see next. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.